good morning, students. A warm welcome to one and all to a brand new edition of Believers Undergraduate Clinics at BCMCH today. This integrated undergraduate virtual classes from on Zoom platform is from Believers Medical College at Pathanamthitta, Kerala. For your information, Zoom capacity has been increased to 500 by His Grace, our beloved Metropolitan, for which we faculty and students are extremely grateful. Looks like we are sitting in a vast tabletop live auditorium, unbelievable. So everyone can join in chat box and quiz, okay? So you all know the attendance for these undergraduate clinics is compulsory. The topic for today is head injury or traumatic brain injury. As for the usual classes, we request the students and attending faculty and esteemed audience to please make this class an interactive session by posting questions and answering in the chat box. So students, on your mark, get set, here we go. The first presentation for today is by the Department of Surgery, which will be followed by discussion on the topic by the Department of Neurosurgery, topped up by a quiz on traumatic brain injury by the Emergency Medicine Department. This session will be chaired by Senior Professor of Surgery, Dr. Janendra Kumar sir. So the first topic coming, we'll have Dr. Tony Matthews, approach to a patient with head injury by a young and dynamic assistant professor in surgery. Dr. Tony Matthews has done his MBBS from Government Medical College, Kottayam. He did his postgraduate training in general surgery from SN Medical College, Bagalkot, which is affiliated to RGUHS Bangalore. He did his senior residency in Father Muller Medical College, Mangalore, before joining Believers Medical College as assistant professor. So his passion, his areas of interest is laparoscopic surgery, thyroid surgery, head and neck surgery. So he's the apt person to speak to you on head injury today. So handing the mic over to Dr. Tony Matthews on the topic, approach to a patient with head injury. Over to you, sir.
Start. Very good morning to all. Am I audible? Thank you, Elizabeth Madam, for those kind words. Without wasting time, we will go to the topic, approach to a patient with traumatic brain injury. For undergraduate students, this topic is of very important for two reasons mainly. First one, in exams, you will get a lot of questions from this particular topic. And second one, after passing exams, you will be seeing and managing lot of head injury cases in casualty. So that time you should know how to manage this patient, when you should admit a patient, when you should ask for a CT, when you should ask for a neurosurgery consultation and all. So in this topic, I will try to cover all these things in a limited span of time. Traumatic brain injury, it is the most common cause of death among young adults, not only in India, all over the world, both in developed and developing countries. So hence it is often called as silent epidemic of modern times. Not only the mortality we are worried about, majority of a good percentage of victims who survive traumatic brain injury are living with significant disabilities or morbidity. So this can cause a lot of burden of socio-economic burden on both on the patient and but on the families. In simple terms, we can define traumatic brain injury as brain dysfunction secondary to an external mechanical trauma. It can be a blow, it can be a jolt, anything. It can be due to a penetrating injury or it can be due to a blunt injury. Blunt injury can be accelerating injury or decelerating injury. There are different types of classification for traumatic brain injury. Clinically, we can classify like mild injury, moderate injury, or severe injury, or we can classify as a focal injury or diffuse injury. For the time being, we will concentrate on this particular classification of traumatic brain injury, like primary injury and secondary injury. Primary injury means it is brain injury caused by the mechanical force at the time of impact. Secondary injury means it is the physiological response of brain cells to the primary injury. So it can develop over a period of hours. Sometimes it may take even days to develop secondary injury. Primary injury, actually, there are different types of primary injury. When I tell the examples, you will come to know. Primary injury can be a simple concussions, or it can be a contusion. It can be a extradural hematoma or subdural hematoma. It can be a traumatic subarachnoid hemorrhage, base of skull fracture, etc. In secondary injury, the primary injury already happened before patient came to the casualty. So we should be concentrating on to the secondary injury. Our main purpose of management is to prevent or minimize the secondary injury. So when you are managing a acute brain injury or traumatic brain injury, our main purpose is to prevent or minimize the secondary brain injury. This should be in your mind always. So how we should avoid the secondary injury? We should avoid hypoxia, hypotension, and we should avoid increase in intracranial pressure. This is the basis of management of traumatic brain injury. So usually I will tell students while you are studying a particular surgery topic, you should start with the anatomy. But for this particular topic, I would say you should know a good amount of physiology also. Normally, especially the auto-regulation of blood supply of the brain. Normal cerebral blood flow is around 55 milliliter per minute for every 100 gram of brain tissue. If it is falling below 20 ml, we can tell there is some sort of infection. If the hypoxia is persisting, it can cause an infection. So cerebral blood flow depends upon the cerebral perfusion pressure, which is the difference between mean arterial pressure and the intracranial pressure. So from this equation formula, you can understand that if you want to increase the cerebral perfusion pressure, intracranial pressure should be low. So coming to like any other polytrauma patient, we should apply the principles of advanced trauma life support or ATLS in case of a head injury patient also. So our main aim is to rapidly identify and treat life-threatening injuries. In case of elective cases, what we used to do, we will take history, then we will examine the patient, then we will ask for investigation, then we will arrive at a diagnosis, then only we will start treating the patient. But in case of a polytrauma patient or head injury patient, we have to simultaneously evaluate and treat the patient. Our main thing is that lack of definitive diagnosis should not delay the application of an indicated urgent treatment. We all know primary survey includes examination of airway, breathing, circulation, look for indisability, and proper exposure and examination of the patient. Coming to first thing, examination of airway with the cervical spine stabilization. First, whenever a patient comes to casualty, first thing we have to do is we have to make sure that airway is patent. So for that, we will try to elicit a verbal response from the patient. So we can ask patient, what is your name? If patient is able to answer you, patient is telling his or her name, that means that there is no immediate threat to the airway. So suppose if patient is not able to speak, it can be due to two reasons. There may be some obstruction to airflow or his mental status may be depressed. Noisy breathing, severe facial trauma, multiple facial bone fracture, all these are the telltale signs telling that there may be a airway obstruction. So if you are suspecting an airway obstruction, first you have to open the mouth and see whether there is any foreign body, whether there is clot, whether tongue is fall back, all those things you have to see. If there is secretions and blood, you have to suction all these things out. These maneuvers like jaw thrust, chin lift, all those things can aid you make a patent airway. Once airway is patent, you may have to insert oropharyngeal or nasopharyngeal airway. In some cases, you have to intubate the patient, especially if the GCS is very poor, if patient is agitated, ABG is showing hypoxia, hypercarbia, or if there is active bleeding into the respiratory tract. All those cases, we may have to put patient, we may have to intubate the patient and connect to a ventilator. In extreme cases, sometimes we may have to do emergency cricothyroidectomy. Always in a polytrauma patient, we should assume that a patient is having some injury to the vertebral column or injury to the spine. So cervical spine protection includes the use of hard cervical collar, and always we should make sure that maintenance of log roll technique for the movement of patient from one place to another. Coming to breathing and ventilation, all head injury patients should receive high flow oxygen whenever they reach the casualty. As I earlier said, main aim is to prevent hypoxia. So all patients should receive high flow oxygen. Then we have to do a rapid or quick respiratory system examination. We have to look for any tracheal deviation. We have to look for any paradoxical movements of any part of chest. We have to look for any displacement of apical impulse. We have to auscultate and see whether there is any decreased air entry to one side. All we are doing all these to identify any life-threatening chest pathologies like a tension pneumothorax, massive pneumothorax, flight segment, etc. If any of these things are there, we may have to do a tube thoracostomy. Tube thoracostomy or ICD, intercostal tube insertion, is a very basic life-saving procedure. We can, by doing this simple procedure, we can actually save lives. So everybody should know, every practicing doctor should know how to put a chest tube safely. Not only the surgeons, every practicing doctor should know how to put a ICD. Coming to circulation. So after assessing the airway and breathing, we have to check the hemodynamic status of the patient. Immediately after reaching the casualty, we have to put a 2 large bore intravenous cannula. While doing that, we should withdraw some blood for cross-matching and basic investigation. If patient is having hypovolemia, always don't remember to tell to arrange blood, keep it ready for transfusion is required. So we have to look for any hypotension. We have to look for whether there is any tachycardia, look for any peripheral extremities are cold or what. We have to look for the urine output, how all these things we have to check. If patient is having hypotension, we should treat the patient as hypovolemic. You know, there are different types of shock. There are circulatory shock, distributory shock, septic shock, different types of shocks are there. But in a polytrauma patient, even if patient is having head injury, always take it as a hypovolemic shock, and look for any source of bleeding. So immediately, if patient is having hypovolemia, we should resuscitate with the large quantities, 1 to 2 liters of warm crystalloid solution. While prescribing the IV fluid, always make sure that we are giving isotonic or slightly hypertonic solution. Don't give hypotonic solution. If you give hypotonic solution, what will happen? This hypertonic solution example is DNS. So if you give DNS, what will happen? Those sugar part will be converted to carbon dioxide and water. This remaining water, it will enter inside the cell and causes cells to swell up. So in turn, if you give hypotonic solution, we are indirectly increasing the intracranial hypertension. So if the patient is having severe hypovolemia, we should treat with the blood and blood products. Our initial aim for resuscitation is to keep the systolic blood pressure more than 90 millimeters of mercury. Coming to disability, after that we have to check for the we have to do a rapid assessment of neurological status. Level of consciousness we can check by assessing the GCS score. And then we have to assess for the pupil. Pupil, you have to tell what is the size of pupil in millimeters, whether it is reacting to the light. Reacting to the light means whether it is normally reacting, diminishedly reacting, or is there any absence of reaction to the light. Then we have to check for any anisocoria, difference between the size of the two pupil. Then we have to check for any gaze palsies or any disconjugate gaze. All those things you have to check while checking the pupil. The spinal cord is closely assessed by visualizing movement of extremities, whether patient is able to move his hands and limbs. Next, few words about the Glasgow coma scale. Glasgow coma scale or GCS is a clinical scale used to assess the conscious level of consciousness of a patient. Although it was initially put forward by two neurosurgeons named Brian Janet and Graham Teasdale, both of them are neurosurgery professors in the University of Glasgow. Nowadays, we are using this GCS scale for every acute emergency patient, not only for surgical patient or head injury patient. GCS is being used for all emergency patients or all patients require intensive care. So we are assessing the level of consciousness by assessing the eye opening response, verbal response and motor response. And you can see that the maximum score possible is 15 and minimal score possible is 3. Even for a death patient is dead, the GCS score is minimum score is 13. Usually this is a favorite question for people in the MCQ test and all. What is the maximum score? What is the minimum score? There are few drawbacks for this particular GCS scale. Thing is that there will be some interpersonal variabilities will be there. So for a particular person, if I tell a verbal response, if for me it may be 5, for some other person it may be 4. So there is a interpersonal variabilities will be there in a GCS scale. And it is not that useful for a pediatric age, especially if it is less than 5 years. For them, we have to change the scale, we have to modify the scale. And some other thing is that for verbal response, sometimes the patient is on endotracheal tube, we can't assess the verbal response. If patient is having profuse lid edema, we can't assess the eye response. And another thing, if suppose if patient is having paralysis and he is paraplegia, if he is not able to move his leg, but if he is actively moving his hand, his motor response will be 6. But he is having paraplegia. Or these are some disadvantages. With all these disadvantages, still people are preferring this scale. It's a simple scale for assessing the level of consciousness. Coming to exposure, after all those things, we have to expose patient and examine the remaining part of body, and always make sure that we have to keep patient warm. We should not allow patient to go into hypothermic. After the end of primary survey, we should do a GRBS, because both hyperglycemia and hypoglycemia is dangerous. So then we have to take a detailed history. Then always make sure that we are giving adequate analgesia for the patient. I like paracetamol or paracetamol or morphine, whatever available, we have to give adequate analgesia. Now we can ask for a radiological investigation like a CT brain or CT X-ray chest or pelvic bones, all those things. Always communicate with the patient relatives. It is very, very important. So always, especially in case of head injury, everybody will be apprehensive, everybody will be tense. Always communicate with the patient relatives regarding the prognosis, treatment or condition of the patient. Always communicate with the patient. Coming to the history of the patient, ideally, while we are doing this primary survey, one person of the team should be taking the history from the bystanders. So what we are interested is that what about the pre-injury state, whether he is under the influence of alcohol, whether he had any chest pains or syncope before the accident, because maybe an MI may be the triggering fact for the accident. We will be treating the head injury, but we are missing the MI part. So whether he had any chest pain, whether he had any syncope or before the accident, and we should know the mechanism of injury, whether it's a low velocity mechanism or high velocity mechanism. If he is falling from height, we will be knowing whether it is approximately how much height he fell from, how much height. Then about we should know whether there was any loss of consciousness. If it was there, how much time it was there. Then length of time taken for extraction of patient from the accident site. And always ask for medication history, whether he is having any diabetes mellitus, hypertension or coronary artery disease, whether he is taking any antiplatelet drugs or any anticoagulant. All those things are very important, especially when we are suspecting intracranial hemorrhage or intraestrural hematoma or something like that. So coming to secondary survey, After completing primary survey, we have to do a proper secondary survey. During secondary survey, we have to inspect and palpate the scalp for evidence of any subclinical hematoma, scalp laceration, any scalp injuries. Scalp injuries can be an abrasion, laceration, or wound. If there is any scalp laceration, if it is bleeding profusely, best thing you can do is just suture it. After giving proper wash and local anesthesia, we can suture the wound. Then we have to examine for the space for the evidence of any fractures, especially to the orbital rim, zygoma, maxilla, etc. Then there are some telltale signs for skull-based fractures, like ecchymosis in the mastoid region. There may be some periorbital congestion of periorbital ecchymosis around the raccoonines. Other signs, telltale signs of base of skull fracture are the CS of rhinorrhea, CS of otorrhea. There may be hemotympanum, etc. Always make sure that we should protect cervical spine. Always, whenever patient comes to casualty, give a hard cervical collar, and always we should examine the cervical spine and both the thoracolumbar spine by doing low roll technique. Look for any tenderness, look for any step deformity, all those things you have to, all polytrauma patient, we have to do proper neck and spine examination. Also, we may have to do a peripheral nerve examination, look for the tone, power, reflexes, sensation, etc. We have to do. So classification of head injury based on, I already told this thing, based on GCS scale, we can classify it into minor head injury, mild head injury, moderate head injury, and severe head injury. Minor head injury means GCS 15 with no loss of consciousness. Mild head injury means GCS 14 or 15 with loss of consciousness. Moderate means GCS 9 to 13. Severe means GCS less than or equal to 8. Coming to the indications for CT in a head injury. Not all head injury patients require CT. These are the indications for CT in a head injury. Everybody should know GCS. If GCS is less than 13 at any point, we have to ask for a CT. If patient is having focal neurological deficit, if patient is having history of post-traumatic seizures, if we are suspecting open depressed or base of skull fracture, multiple episodes of vomiting, all these cases, we have to ask for a CT at an emergency basis. Other indications are if age is more than 65 years, if patient is having any anticoagulation, warfarin or dabigatran, or he is on any antiplatelet drug, we have to ask for a CT. And if the mechanism of injury is dangerous mechanism, high velocity mechanism, we have to ask for a CT. And if there is an antegrade amnesia for more than 30 minutes, we have to ask for a CT. So coming to discharge criteria, when you can discharge a particular patient of a head injury patient. If GCS, for a discharged patient, GCS should be full without any focal neurological deficit. And CT brain should be normal, and patient should not be under the influence of alcohol or drugs. Patient may be having loss of consciousness. Bystander may tell that it is due to alcohol, but we can't discharge patient if he is under the influence of alcohol. And always patient should be accompanied by the responsible adult. And we have to tell the patient in what all cases you should immediately come back to the casualty. If patient is having persistent or vomiting or persistent headache, and the patient is having drowsiness, if he is having any visual disturbances, he should come back. If he is developing any limb weakness also or numbness, he should come back immediately to the casualty. So these are the discharge criteria for a head injury patient. Always remember, it is always safe to admit all head injury patient when we are presenting to the casualty or emergency department. So now if after examining all those things, if you are thinking the patient needs to be shown to a neurosurgeon, always don't hesitate to call neurosurgeon. Tell him detail what is the mechanism of injury. Always remember to tell the GCS. You have to tell GCS like you have to split eye response, motor response, verbal response, and tell. Don't tell GCS is 14 by 15 or 12 by 15. You have to tell specifically what is the GCS. Eye response is how much, verbal response is how much, and motor response is how much. With that, I will just stop here. I will call our neurosurgeon to continue the discussion. Thank you.
Thank you, Dr. Tony Matthews. That was an excellent presentation. So as we all know, we understood now that the patient with a head injury comes to the ED, and in a tertiary care hospital, the emergency ED specialist will first look at the patient, and after that, the ED specialist will call the surgeon on call, and the surgeon will exactly explain to you how he will approach a patient with head injury. And after that, if he can manage, he will manage. Otherwise, he will immediately call the neurosurgeon to the view. So now we have the neurosurgeon, the next class, which will be taken by Dr. Prithvi Burgis, consultant neurosurgeon, Believers Church Medical College. So this discussion on traumatic brain injury will be presented by Sir. He has done his studies from Sri Chitra Tirunal Hospital, and he has 24 years of experience as a neurosurgeon in Indo-American Hospital and Lisi Hospital, Lakeshore Hospital, and finally at Believers Church Medical Hospital. So over to you, sir, Dr. Prithvi Verghese.
Right. All right. Good morning. After that detailed presentation by Dr. Tony, this will be just a topping up. This presentation will be about traumatic brain injury. In this presentation, we will deal with the pathophysiology, clinical features, imaging, and management of traumatic brain injuries. We will start with an aphorism by Hippocrates that no head injury is so serious that it should be despaired of, nor so trivial that it can be ignored. Head injury in the strict sense means injury to the scalp, skull, and the brain. But both the terms, head injury as well as traumatic brain injury, are used interchangeably. We will stick to the terminology of traumatic brain injury or TBI. Coming to the causes of head injury, the statistics show the causes are different in countries. In India, the most common cause is road traffic accident, which makes up around 55% of the cases. In the developed countries, probably because the incidence of RTS are decreasing, falls are the main cause of TBI. Very few quality studies regarding the epidemiology of TBI are available from India. But it is estimated that 1 million people die due to trauma every year in India, and out of which 50% are due to head injuries. These statistics are from a study conducted by NIMHANS a few years back. And the age group most commonly affected is the younger age group, that is 21 to 35. Children less than 15 years also constitute a bulk of patients. And obviously, for obvious reasons, the male to female ratio is 4:1. Morphologically, head injuries can be of three types: closed or non-penetrating injuries, penetrating injuries, and blast-induced injuries, which are not very common in India. This picture shows penetrating injuries. Then, depending on the mechanism causing the injury, TBIs can be either contact injuries or acceleration deceleration injuries. Contact injuries means the injury happens at the site of contact or just beneath the contact. Whereas acceleration deceleration injuries, the injury to the brain can happen in other sites other than the site of contact. Why does this happen? The brain inside the skull is not fixed to it in a rigid way. So a force applied to the head can move the brain and the skull in different ways. In other words, there will be a relative movement between the brain and the skull. So this can cause injuries. When a moving head hits a stationary object, it produces an acceleration type of injury. And if a moving object strikes a stationary head, it produces a deceleration type of injury. When we read about head injuries, we often see these terms, coup and counter coup injuries. So coup injuries means injuries which occur at the site of impact, like here. Because of forces transmitted through the brain, an injury can occur diametrically opposite to the site of impact, which is called the counter coup injury. So what makes brain injury different from injury to other organs is that the brain is enclosed in a rigid container, the skull. The skull has no capacity to expand. The volume of the intracranial compartment is 1,500 milliliters, out of which brain occupies 85%, blood 10%, and CS of 5%. So because the brain is in a closed compartment, in a closed rigid container, increase in volume of one component should be compensated by decrease in volume of the other components. This is the essence of the Monroe-Kelly hypothesis, which was proposed around 200 years back by two scientists, Monroe and Kelly. So when a hematoma or any other mass expands inside the brain, so it has to displace something. So the first thing it displaces will be the CSF. So the CSF will be displaced to the subarachnoid spaces in the spinal canal. Then after the CSF compensation is over, the venous blood gets displaced. And finally, the arterial blood itself will be displaced, and which will lead to ischemia and its consequences. So cerebral perfusion pressure, or the pressure in which the blood is made available to the brain tissues, is actually a measure of the intracranial pressure as well as the main arterial pressure. So blood is pumped by the heart, it goes into the brain, and it has to perfuse across the capillaries. And this pressure is around 95 millimeters of mercury normally. So how do you get this pressure? So normal intracranial pressure is 15 millimeters of mercury. And the mean arterial pressure is 70 to 110. So by subtracting the ICP from the MAP, you will get the cerebral perfusion pressure. So which is normally around 95 millimeters of mercury. Brain is a very vulnerable organ for ischemia. Why is it vulnerable? Is because one, even though it forms only 2.5% of the body weight, it constitutes for 25% of the metabolic rate. Another reason is that it is dependent only on glucose for its energy source. So these two factors make it very vulnerable organ. A complete interruption for 5 minutes will lead to cell death, which is reversible. Which is irreversible. You must remember that in cardiac muscle, it can survive ischemia for 40 minutes, but brain will survive only for 5 minutes. This is a very important curve you are seeing here. This is called the pressure volume curve. You can see the intracranial pressure is plotted in one arm and the intracranial volume is plotted in another arm. You can see the rise in intracranial pressure is not proportional to the intracranial volume. After a certain threshold, the rise in intracranial pressure is very steep. So this is very important in the management of the patient. You have to prevent the intracranial volume from rising beyond the threshold. Head injury can be classified according to the nature into primary or secondary injuries. Primary injuries happen at the time of injury, about which we can do very little. The only thing we can do is probably prevention, which is not a medical science. Secondary injury, this is the area which we can do something. And okay, before we come to the brain injury proper, let us see the type of fractures. Fractures are a type of injury. There are 4 types of fractures. One is a linear fracture, which is usually the shape of a line. If there are multiple lines, it is a comminuted fracture. The fracture can be depressed, where a segment of the bone is depressed below the surface. The skull fracture can be a diastatic fracture, in which actually there is only a widening of the normal sutures. And skull fractures can involve the bones in the base of the skull. Skull fractures can again be classified into closed or open, depending on whether there is an open wound. These pictures show depressed fracture. This is a CT scan showing a depression here. This is a 3D reconstruction of the skull showing a depression. Sometimes depressed fractures can be seen on examination, although not always the case. The basilar skull fractures, or the basal skull fractures, can involve the anterior fossa, middle fossa, or the posterior cranial fossa. And CT scan is the way to rule out basilar fracture. You have to look carefully in the CT scan to see a basilar skull fracture. There are some signs which skull-based fractures produce. One is the raccoon sign. Dr. Tony has mentioned this. I think he had the same picture. This is bilateral periorbital ecchymosis, or otherwise called the raccoon eyes. Here is the original raccoon. Another sign of basilar skull fracture is the battle cell, which is ecchymosis behind the ear. This is caused by fracture of the petrous temporal bone, whereas the raccoon eyes are caused by fracture of the anterior cranial fossa. Another clinical sign of skull-based fractures is CSF otorrhea or CSF rhinorrhea. So when a patient with trauma comes to the emergency department, he may have bleeding from the nose and the ear because of injuries inside the nose or in the ear canal. But how do you differentiate CSF from blood? So basically you have to drip a few drops of this discharge into a linen or a paper. So after some time, it will show a pattern like this if it is CSF. It is called the halo sign. There will be a central region of red blood cells surrounded by CSF. So this is the halo sign. You can see in this photo, the bed sheets are showing the halo sign. So coming to the primary brain injuries, there can be many types of primary brain injuries. These are injuries which happen at the time of contact. And one is the concussion, extradural hemorrhage, subdural hemorrhage, contusions, intracellular hemorrhage, subarachnoid hemorrhage, and diffuse axonal injuries. These are the primary brain injuries possible. A concussion is the commonest head injury, and it is the mildest one. There is actually no structural damage here. It's only a functional loss, which is temporary also. And the reason is some reversible biochemical alterations which happen inside the brain due to the trauma. The patients can present with confusion, headache, dizziness, a ringing sensation in the ear, nausea, etc. The CT scan in these cases will essentially be normal. Coming to the next type of primary brain injury. This is Michael Schumacher. You know, he had a severe head injury a few years back and still he has not come out of it. So he had a diffuse axonal injury. What is diffuse axonal injury? They are caused by acceleration, deceleration forces, as I mentioned earlier. There is structural damage at an axonal level. You may not see a big clot or a contusion in a case with diffuse axonal injury. In fact, the imaging may be normal, CT may be normal. But pathologically, injuries are seen at the gray-white junction, the corpus callosum, or the brainstem. And the patients can present in a wide variety of symptoms, ranging from very mild symptoms to coma. MRI is the investigation of choice to diagnose diffuse axonal injury, which shows punctuate hemorrhages at the gray-white junction and the corpus callosum. Coming to the next primary brain injury, which is the extradural hematoma, it happens in 2% of the injuries. It is usually caused by injury to an artery, and commonly the middle meningeal artery, although other meningeal arteries also can be injured. And 85 to 95% of extradural hematomas are associated with skull fracture. Extradural hematomas usually affect young age group, and classically there is a lucid interval. Lucid interval means a period of consciousness or a period of normal consciousness between two periods of unconsciousness. This is lucid interval. Classically seen in extradural hematoma, but can also be seen in other types of hematomas. In the CT scan, the extradural hematoma occurs between the skull and the dura mater, and it has a biconvex shape in CT scan. The next one is the acute subdural hematoma. Chronic subdural hematoma is something different. We will not deal in this presentation with chronic subdural hematoma, which is actually a consequence of head injury, but it happens later. So we will not deal with that. We are talking about acute subdural hematoma here. This is hematoma between the dura and the arachnoid. And acute subdural hematomas or SDHs are mainly due to injuries to the veins. And studies show that this is the commonest type of intracranial hemorrhage in a head injury, associated with high mortality and morbidity. In the CT scan, the acute subdural hematoma has a concavo-convex shape or a concentric shape. Then the next type of brain injury is the contusion or the intraparenchymal hemorrhage. The distinction between these two types of hemorrhages are very unclear. But if more than, it happens, it's a hematoma which happens inside the brain parenchyma. If more than 2/3 of the lesion is blood, it is considered intracranial hemorrhage, ICH. Whereas if it is less than that, it is called a contusion. So again, both these terms are used interchangeably. And contusions and intraparenchymal hemorrhages are common in the temporal and the frontal lobes. This also has the property of increasing in size over the next few days after injury. Subarachnoid hemorrhage is a relatively benign injury. It is common, and trauma is the most common cause of subarachnoid hemorrhage, whereas all subarachnoid hemorrhages are not caused by trauma, can be caused by other diseases like aneurysms or AVMs. And the difference in traumatic SAH or subarachnoid hemorrhage is that the hemorrhage is seen in the cerebral convexities, whereas in aneurysmal hemorrhages, they are usually seen in the basal cistern. Even though they can cause some complications later, they generally have a favorable outcome if they are isolated injuries. So what is coming to the secondary injury? What is secondary injury? We can summarize that all the deleterious events which happens after the primary injury can be together called as the secondary injury. So primary injury, secondary injury. Then it may take minutes or days to fully develop into a secondary injury. So there are many mechanisms involved in the secondary brain injury. Basically, it starts with the primary injury. The primary injury causes a disruption of the blood-brain barrier, and there is indiscriminate presynaptic release of neurotransmitters, which activates postsynaptic receptors. There is an influx of sodium and calcium into the cell, a depletion of ATP inside the cell. Glucose uptake is reduced, and there is mitochondrial failure. And there is production of free radicals, which further increase the injury. So these are the main mechanisms in very brief detail. So there are many factors which can aggravate the secondary injury, and these are the areas which treatment can be attempted. There are systemic factors like hypoxia, hypotension, hypercarbia, hyperthermia, anemia, electrolyte imbalances. Then intracranial causes like brain edema, elevated intracranial pressure, which can be caused by secondary brain injury itself, again can cause increased secondary injury. Seizures, infections, all this can aggravate secondary brain injury. So this is a patient who is still in our ward in BCMCH. He had come with a severe head injury, but his scan in the initial days was normal. But later, after a week, this was his scan, which shows extensive edema of one side of the brain and the other side. So this is a classical secondary brain injury. There is midline shift also here. So brain edema, secondary to secondary brain injury, can cause herniation of brain inside the cranium. So parts of brain can herniate from one compartment of the brain to the other compartment. These are called brain herniation syndromes. The brain herniation syndromes can either be the cingulate herniation or the subfalcine herniation, in which a part of the frontal lobe herniates across the false cerebrum, false cerebri. Then a part of the medial temporal lobe called the uncus can herniate down through the tentorial nodes. Then the brainstem itself can descend down to through the tentorium, which is called the central herniation. And if there is a macellation in the posterior fossa, the cerebellar tonsil can herniate through the foramen magnum. So these are the main types of herniation syndromes seen. Each one produces different clinical pictures. So the most common herniation, of course, is the subfalcine herniation, but the most striking or the dangerous one is the uncal herniation, which is common in mass lesions. The clinical features of which are an ipsilateral dilatation of the pupil. Suppose the uncus herniates on the right side, the right pupil will dilate. And there will be contralateral hemiparesis. This is because of the compression of the ipsilateral corticospinal tract. So there will be contralateral hemiparesis. And because of there is compression of the brainstem, midbrain to be exact, there will be altered sensorium. So if you see a person with dilated pupil on one side, and if he is fully conscious, don't ever consider he is having a uncal herniation. Then Kernohan's notch is a false localizing sign, because normally uncal herniation produces contralateral hemiparesis, but sometimes it can produce hemiparesis on the same side. This is because the uncal herniation causes pressure on the opposite corticospinal tract. So this is actually a false localizing sign, Kernohan's notch. Coming to the symptoms and signs, patients can present just with headache, vomiting. Some may be in altered sensorium, some may be in coma. There may be altered respiration. There can be bradycardia, hypertension, fluid leak, CSF leaking from the nose or the ear. There may be pupillary changes and focal neurological deficits. One important thing to mention regarding the symptoms is traumatic brain injury will not cause, isolated traumatic brain injury will not cause hypotension. So if there is hypotension in a patient suspected of having a head injury, always you have to rule out other causes like spine injury or other organ injuries. Cushing's triad is a clinical feature seen in head injuries. It's a triad of widened pulse pressure, that is increased systolic pressure and a decreasing diastolic pressure, bradycardia, and irregular respiration. So this is a triad. So all these responses are the responses of the body to maintain the normal cerebral perfusion pressure. So bradycardia, actually what the body means is that it increases the stroke volume so that the CPP is maintained. Widened pulse pressure, again, because of the increasing systolic pressure, it is an attempt to increase the cerebral perfusion pressure. So the imaging, the imaging of choice in head injuries is a non-enhanced CT scan. This is the imaging of choice. A contrast examination is not necessary for acute injuries. But MRI has a role, not in the acute stage. MRI takes, as you know, MRI takes a longer time to do. It's not possible for MRI to be done in a ventilated patient or a patient with implants. So MRI is not generally done in an acute head injury. So the investigation of choice is a non-enhanced CT scan. But MRIs can show small contusions and diffuse axonal injury if it is taken after 2 or 3 days. X-rays are no longer used for head injury. And investigations like SPECT and PET are not useful in acute TBI. They may be useful to prognosticate the patients after stabilization. So what is our aim in treating head injury? Our aim, and the only possible aim, is to prevent or minimize secondary injury. Management of TBI can be divided into 4. One is initial management, which Dr. Tony has already mentioned. Second is the neuro assessment. Third is imaging. And fourth one, to recognize and treat raised intracranial tension. So the golden objectives of the initial management, that is prevent hypoxia, hypotension, and hypercarbia, still applies to the management of the injured patient. So initial management, I will not go into that. So neurological assessment, a quick history has to be taken. Neurological examination basically involves assessment of the level of consciousness and assessment of neurological deficits. Dr. Tony has told about GCS scoring. So this is a scale to assess the consciousness of the patient. It is not to be, it has the drawback of not having details of pupils or neurological deficits or vital signs. But still, it is very useful to assess the consciousness of the patient. There is a modification of Glasgow coma scale after 40 years of its introduction. The Glasgow coma scale, many people have modified it, but this is one modification which I think has come again from the University of Glasgow. So this is called the Glasgow coma scale pupil score. So here the pupillary reactivity also is taken into account. It's called the GCSP. The highest score is 15, and the lowest score is 0 here. And GCSP is obtained by subtracting the pupillary reactivity from the GCS. Based on the GCS, head injuries can be classified into 3: mild, moderate, and severe. Mild head injuries from 85%, and the GCS is 13 to 15. GCS of 9 to 12 is called moderate injury, and GCS of 3 to 8 is called severe head injury. So indications of CT scan, this is as per the NICE guidelines, or it's a UK-based guideline, National Institute of Health and Care Excellence guidelines. So I will not go into details, you can read it up. Not all patients need a CT scan. Indications in children are a little different. And children, as far as possible, you must avoid a CT scan because of the radiation. As you know, CT scan, a normal CT scan of the brain has radiation enough equal to 20 chest X-rays. So as far as possible, it should be avoided in children. In children, another alternative, I mean, especially neonates or young children, you can do an ultrasound of the brain through an open fontanelle. We are doing this here in BCMCH. It is not a very sensitive procedure, but it can show big lesions. There is no radiation involved here. It's a bedside procedure. So coming to the final step of managing secondary brain injury is recognize and treat raised ICP. You must always remember this curve, the pressure volume curve. So these are some indications where mannitol is given in casualty. Mannitol is an osmotic agent which is rapidly used for rapidly controlling the raised ICP. So if a patient comes to the casualty and there is a strong suspicion of head injury, but you have not done a scan or assessed him, provided he is hemodynamically stable, you can give a bolus of mannitol, 150 ml of mannitol. So ideal management of head injury should be based on the intracranial pressure. So intracranial pressure can be monitored by different catheters or implants inserted into the brain. It can either be an intraparenchymal catheter, epidural catheter, an intraventricular catheter, or a subarachnoid catheter. So in all these ways, invasively, intracranial pressure can be monitored, and the pressure can be directly read out from the monitor. This is a normal ICP wave. It has 3 components, whereas this is an abnormal wave. The second component, or the P2, is larger in this abnormal wave. This is a trend recording involving several minutes of ICP, which shows plateau waves. Plateau waves are characteristics of raised ICP. The normal ICP, as I told you, is from 0 to 15 millimeters of mercury. So there are other monitoring methods, invasive monitoring methods available. This should be the ideal setup in an ideal intensive care unit, neuro-intensive care unit. You can do a jugular venous oximetry You can do a brain tissue oxygen partial pressure measurement, microdialysis of cerebral fluid, interstitial fluid, transcranial Doppler. All these methods can be used to monitor intracranial events. Coming to the management of raised ICP, the goals: maintain ICP around 22 or between 20 and 25. This is one of the goals. And maintain a cerebral perfusion pressure of more than 60. You continue your objectives of preventing hypoxia, hypotension, and hypercarbia, because all these three will lead to further worsening of intracranial tension. So, medical management of raised ICP starts with simple measures like elevating the head and sedation. Analgesia is very important because pain can increase the intracranial tension. Fever should be controlled. Hypertension should be controlled. And seizures should be controlled. Electrolyte imbalance, especially hypernatremia or hyponatremia, can cause further aggravation of intracranial tension. If the intracranial tension is not controlled by simple measures, you may have to go for heavy sedation using midazolam or propofol, and sometimes paralysis also might be necessary. Osmotic agents are commonly used to control intracranial tension. The common agents used are mannitol and hypertonic saline. Hyperventilation is another tool used to reduce intracranial tension, but it has to be used only over a short period. Hyperglycemia has to be avoided. Sugar containing or dextrose containing IV fluids ideally should not be administered. Hypothermia, barbiturate, coma, and steroids, they do not have much role in treating raised ICT. Now, indications, surgeries. The surgeries done in cases of head injury can be of three types: either a craniotomy and evacuation, elevation of depressed fracture, or a decompressive craniectomy. Each has its own indications. So craniotomy is raising a bone flap, cutting a bone flap from the skull and exposing a hematoma. So this is used to evacuate a hematoma inside the skull. So you cut out a bone flap and expose the brain. So indications are well defined for each type of hemorrhages. The EDH is operated if the volume is more than 30 cc or the thickness is more than 15 millimeters, or there is a midline shift of 5 millimeters. This is done irrespective of whether there is intracranial tension or not. Similarly, SDH is evacuated if the thickness is more than 10 millimeters or a midline shift is more than 5 millimeters. ICH should be evacuated if the volume is more than 50 or volume more than 20 in an important area. So this is an operative photograph of a subdural hematoma. So you've done a craniotomy and then open the dura and then you're seeing this clot. This is a subdural hematoma. This is the operative picture of after evacuation of a contusion here. This is the craniotomy edge, and you can see the cut dura here, and this is the brain with the veins on the surface. This was the area of contusion. It was evacuated. Now coming to treatment of fractures, elevation of depressed fractures are considered if the depression is more than the thickness of the skull or it is heavily contaminated. or it is associated with a dural injury. Or sometimes, if all the three are not present, if it is in a cosmetic area like forehead, also sometimes depressed fractures are elevated. This is a picture showing a depressed fracture after it was elevated. So usually this is elevated and not fixed, or maybe fixed with some absorbable materials, but not with implants. The third surgery is decompressive craniectomy. The indication is a sustained elevation of intracranial tension, which is refractory to medical management, and there is no focal lesion in the brain to be evacuated. So what is done here is a large bone flap is cut from the skull so that the brain can expand into the additional space available. So it can be done in two ways. It can be either be a bifrontal craniectomy, or it can be a unilateral hemicraniectomy. And the removed bone flap is normally not replaced at the time of closure. And it will be preserved in either the patient's abdominal wall or in the deep freezer. And once the secondary injury subsides, maybe after a few weeks or months, it is replaced and fixed back. So as I told you, most of the head injuries are mild head injuries, 85% or more, and they resolve without any long-term sequelae. But moderate and severe head injuries have a lot of sequelae. It's are listed here. I will not read it now. So the outcome of traumatic brain injury can be assessed with another scale. Again, having the name Glasgow in it. It is called the Glasgow Outcome Score. So the outcome is divided into 5, GOS 1 to 5. 1 is death and 5 is mild or no disability. So that is how you assess outcome of a head injury. Glasgow Outcome Score. Thank you. The color red is chosen to remind you about our director's instruction to you to wear red next Monday. Thank you.
Excellent. Okay. Excellent talk, sir. This talk is Facebook. All medical professors will take to sir. Next, the doctor comment. This question is this way.
Yes.
By the junior consultant of ED, he is now the acting HOD of emergency department, which is Dr. Shami Douglas Lambert. As we all know, emergency department is always the throbbing heart of any tertiary care hospital. And Dr. Shami Lambert handles life and death issues daily, moment by moment. So as we know that Dr. Shami will lead you in an exciting quiz today. And Dr. Shami did his MBBS from Russian State Medical University in 2003, and he has done his Master's in Emergency Medicine from George Washington University in 2015. He is currently working in the capacity of junior consultant in ED in Believers Medical College. Request the students and faculty to make this an interactive session, and you must answer within 30 seconds in the chat box once the question is asked. So, Shami, start with the rapid fire quiz in traumatic brain injury. Over to you, Shami.
Hey. Hi guys, Dr. Shami here. So you all had a feast of information knowledge, say starters by Dr. Tony, Main course by Prithvi sir. Let's go something sweet now, for the obvious reasons. Yeah. So in ER, we usually have a pre-test and the post-test before and after a session. This is more of a post-test rather than a quiz competition, because I think sir has gone through almost all the questions which I'm going to ask you guys. So I think we'll go for the first question. So the first question is, a patient with history of fall with head injury, on arrival, he opens his eyes to painful stimuli. He's confused, withdraws to pain. So what is the best GCS that you can give him? So he opens his eyes to pain. He's confused, withdraws to pain. Option A is 9. Option B is 8. Option C is 10. Option D is 11. So most of you are answering option D. So some is C. Okay, fine. So nice, good, good, good. So I'll go for the answer.
So
Majority is saying C, is it?
yes.
Okay, good job, guys. It's okay. C is the answer. So the previous question, the patient is categorized to which severity of head injury? Is it severe, mild, moderate, or concussion? Just bring this up. Just a minute. Yeah. A is severe, B is mild, C is moderate, and D is concussion. So I can see BC, moderate, good, 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 awesome, very nice. MG, Jerry, Sneha, Sajna, everybody saying C. Impressment, nice. So the answer is moderate again. Good job. So sir has gone through the whole Glasgow coma scale in detail. Just to make it a little more easier, probably. Eye opening is very clear to all. So you call somebody, they'll open their eyes. That is verbal. Normal spontaneous is 4. To pain is 2. Someone is not opening their eyes, it's 1. Obvious? Okay. So verbal. So what is verbal? Someone is conscious oriented, telling you the story, what happened. Is verbal response. So you give 5 points for that. If someone is confused, ഞാനിപ്പോ എവിടാ ഇതിപ്പോ എന്താ എന്ന് വിശ്വ എനിക്ക് ചോദിക്കുന്നത് 4. Confused. And someone is giving inappropriate responses. So it's talking inappropriate things. Okay. So that is 3. And someone makes incomprehensible sounds, you give 2 points. And no verbal response, it's 1. Okay, great. And motor, the best motor, if someone is moving his limbs without any command, it's 6. Someone is localizing to pain, that is, you give him pain. If you're putting a candle, you can come and hold your hand, it's called this. You give 5 points. And when you put a candle, it takes your hands off, it's 4. And decorticating, that is abnormal flexion, is towards the core, this is known as your decorticating position. This is decerebrating. And there is nothing, it's 1. Okay. So how do you classify the mild, moderate, and severe? Mild is up to 15, moderate is 9 to 12, severe is 3 to 8, which I think you all will be very aware of. Next question. Fine. So pediatric Glasgow coma scale. It's almost the same, but the child won't be able to talk to you very clearly. So eye opening, yeah, spontaneous to verbal commands, to pain, to responses more than 1 year. But if the child is less than 1 year, he won't be able to give you commands. I mean, to respond to commands. So you shout to the child might respond. If you give him a pain, the child might respond. So accordingly, the best motor for the child is almost the same actually as an adult. For the verbal, as you can see, 5 you give. If the child is smiling, cooing, or crying appropriately, you give 5. And 4 is given inappropriate words or cries according to the age. 3, again, crying and screaming. 2 is grunt, and 1 is no response. Yeah, that is shown. Next question. Okay, I'll go for the next question. So I'll give a case scenario. A 34-year-old male is evaluated in the ER for worsening headache, nausea, 2 episodes of vomiting, 2 hours after hitting his head in a fall from top of a 6-foot ladder. So vomiting, fall from 6 foot. These are the catchwords. On examination, his temperature is normal, BP is good enough, 120/70, heart rate is good enough, 86, respiratory rate is 14, GCS is the best you can get, 15 and 15. So what do we do with them? Which of the following is the most appropriate immediate step in his management? So do you want a CT with contrast? Do you want a CT without contrast? Do you want admission observation for 6 hours or an MRI? A, B, C, or D? I can see a lot of B, C, B, C, B, C, B, B. Mostly that's B. Nice. And C comes in. And C comes in and B comes in. Great, great. It's mostly B. Correct. So the answer is CT without contrast. Why? So a lot of guidelines are there. So I'll give you the catchwords. He had a dangerous mechanism of fall. That is a mechanism of injury, fall from more than 6 feet height. And he has vomiting. So the ASAP, American College of Emergency Physicians and the Centers for Disease Control, they've come with some recommendations. That is, after a mild head injury, if the patient is having focal deficits, vomiting, severe headache, any signs of base plus skull fracture, Glasgow coma scale, GCS scale less than 15, coagulopathy, and dangerous mechanisms. In this, you can see there's vomiting and dangerous mechanism, fall from more than 6 feet of height. So answer is you take a CT without contrast. Good job. So the next question is identify the brain injury. Is it A, subdural? Is it B, extradural? Is it C, subarachnoid? Is it D, intraparenchymal? It's too easy. It's too easy. It's too easy. It's too easy. So extradural, extradural, extradural. A, okay. Subdural, is it? The catchword is how I used to remember this with the shape of it. It looks like idli for me. Concave. Okay, so most of you have written answer as B, and some are writing it as A. Very few. Okay, great. So I'll go for the answer. It's EDH. Good, extradural. Answer is B. So identify this one. Is it EDH, extradural, subarachnoid, subdural, or diffuse axonal? C, mostly. Mostly C. Yeah. C. 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 A lot of C's. Very few B, a lot of C's. I'm proud. Good job, guys. You were listening to the class. Nice. 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 Okay. The answer is subdural C. Good job. So just to give you a picture of the different types of bleed. Subdural, it's crescent shape, mostly due to the tear in the bridging veins. Okay. Extradural, shape of an egg, idli, biconvex in shape, due to the mostly due to the tear of the middle meningeal artery. Subarachnoid, ruptures of your aneurysms, and the last one is intracerebral hemorrhage, which you have gone through the whole session, the class. So has explained it wonderfully well. Cool. Next question. So what is Monroe-Kelly doctrine? What does it describe? A, is it cerebral perfusion? B, is it pressure volume relationship with the intracranial cavity? C, physiological electrical function of the brain? D, classification of injury. Everybody knows the answer. Everybody is B. 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 Should I wait? I mean, everyone knows the answer. Good job. Proud teachers. Proud us. Answer is, should I go for answer again? Answer is B. So you have brain, you have CSF and blood in a tight cavity, your cranium. So that's what is the whole Monroe-Kelly doctrine is about. I think I'm not going to detail up this thing because sir has gone through it. Probably this picture will help you all more. Narrow it down. This is a perfect picture. Normal picture, the brain, CSF and the blood. Imagine a mass comes up, These two fellows will try accommodating. Your CSF in the blood is trying to accommodate the mass in it. Your perfusion is maintained, everything is going on well. But once the mass grows out, your brain can't go anywhere else. This goes bad, and inevitably death happens. Okay, cool. So, what is the formula for cerebral perfusion pressure? CPP. Is it MAP minus ICP? Is it MAP plus ICP? Is it ICP minus MAP? Is it CVP plus ICP? CVP is central venous pressure. Everybody is answering it as A. Good, 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 good. Archana, Sridhar, Lakshmi, Aiva, Hans, Anai, Riya, Lakshmi. I don't see something, but it's okay. Okay, good job. Good. So the answer is mean arterial pressure minus ICP gives you cerebral perfusion pressure. So I'm not going to the details. Everything has been taught to you well. You answered it well. So next question is, what is the target map to be maintained in TBI, traumatic brain injury? Little controversial. Different books is different, but I wouldn't be upset if you all answer it wrong. B, C, D, D. Okay. Everything like different neurosurgeons have different opinion. Like yeah. So I think I'll go for the answer. B, C. Answer is C actually, but it's okay. I'll give to all of you all because idea is the only thing that you can control among all these three to maintain a CPP is your map. So yeah. So let's go to the next question. What is the normal intracranial pressure? Is it 0 to 10, 10 to 20, 25 to 30, 0 to 15? Again, controversial, but 10 to 20 and 0 to 15 is good. D, D, B, D, B, D, both are good actually. Good, good, good. 5 to 15. Yeah. So some books says 5 to 15, some books says 10 to 20. So anything above 20 is high. When your pressure is above 20, it's bad. Okay. The explanation has already been given done. So what is Cushing's triad? Cushing's triad includes hypertension, irregular respiration, along with A, is it distended neck veins, B, is it bradycardia, C, is it hypothermia, D, is it muffled heart sounds. So bradycardia, bradycardia, B, 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 B. Very clear, very easy. Good listening to class. Nice. Good. Answer is bradycardia. So Cushing's triad is something very opposite to your patient who's in shock. In shock, BP goes down, heart rate goes high, respiration goes high. In Cushing's, it's completely opposite to it. So please don't get confused with Cushing syndrome. It's totally different thing. Okay. It's named after Williams Cushing. So you know what is change stroke breathing also. Irregular breathing pattern, sometimes they go into apnea. It's very serious in a head injury patient. If someone is having Cushing's triad, they might die. So please watch out for this. Uncal herniation, the nerve affected in uncal herniation is A, trochlear nerve, B, oculomotor nerve, C, trigeminal nerve, D, facial. Everybody knows it. B, 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 A, there's only B, Sneha B, Nancy, Aksha B, Netal B, Ajaja B, everybody's B. Okay, so again, so let us thought you all well. Types of herniations, translar, uncal, cerebral, central and subfascial. Okay. So what is lucid interval? Lucid interval is predominantly seen in which traumatic brain injury? Most commonly seen in subdural, extradural, subarachnoid, intraparenchymal. Awesome. 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 So good to see everybody's answering. B, 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 B. Next. Nice.
It's seen in extradural. It's so what is lucid, by the way? It's normal. It's a normal phase. Temporary improvement in patient's condition after TBI. So once he might have a loss of consciousness and he comes back to normal, that period is known as lucid interval. 20 to 50% of the patient with EDH develop this thing. 20 to 50. So this question probably was not a part of the class, but yeah, I'll make it easier for you. So Nexus criteria. Nexus stands for National Evaluation of Radiography in Ultrasound, National Emergency X-ray in Utilization Study. That is for your C-SPAN protection. The components of Nexus criteria for C-SPAN protection consist of A, age more than 65, distracting injury, dangerous mechanism, extremity paresthesias, raccoon's eye. B, age more than 65, extremity paresthesias, dangerous mechanism, which is fall more than 3 feet, axial load injury, high speed, bicycle collision, motorized vehicle, recreational vehicles. C is focal neurological deficit, midline spinal tenderness, altered level of consciousness, intoxication, distracting injury present. This is for, like, imagine a patient comes to ER with a trauma. Should you put a collar for him or not? A cervical collar for him or not? Should you take a X-ray or a CT or an MRI for this patient? So this criteria helps in deciding should we do imaging or a protection for this patient. So a lot of these, nice. A lot of these, because it's such very easy. Right? Hold you. Okay, so Nexus criteria. Answer is C. Sorry. Well, few have said C. Good, you all have read the question. Or some of you have attended the trauma workshop by our emergency team. So predominantly there are two criteria to protect someone's cervical spine. It's Nexus and Canadian. Nexus, as I told you, it's National Emergency X stands for Radiography Utilization Study. Okay, so it says when someone is having a deficit, post-trauma, someone is having numbness to his hands or any part of the body, deficit is there, or GCS is low, and or someone is having midline cervical tenderness, or he's got an altered sense of consciousness, or if he's intoxicated, or there is a distracting injury. So imagine he's got a cervical spine injury, but along with it, he has a run-over injury through his thigh. Both bones of his leg is broken. So that pain will be more severe than a cervical spine injury. So that is a distracting injury. So in case anybody is having all these, any one of these five, you have to put a C-collar, take a cervical spine imaging, either an X-ray or a CT or an MRI, rule out spinal cord injury, then remove the collar off. Canadian is something similar but more complicated. So we all follow Nexus criteria in our department. So next time you see a patient with a collar in our department, it's mainly because of this criteria. So the next question, okay. So identify these signs. Yeah. And where do you see these? Subdural, extradural, subarachnoid, base of skull fracture. Yeah, that is raccoon's eye and battle sign, which is, I'm good. Thank you. Yeah. Awesome. Everybody's got the answer correct. Nice. Good job. Oh, nice. Someone's answer also Jerry Philip. Raccoons and battle sign. Nice. Good job. Okay, nice. Answer is D, base of skull fracture. So, other than the battle sign and the raccoon sign, you have CSF, rhinorrhea, otorrhea, hemotympanum. You might even get the facial and eighth nerve dysfunction also. Good job. I'll make it a little more easier. Simplest of the lot. What is the GCS for a dead or the least GCS that you can get for a person? 0, 1, 3, minus 1. See. Sorry. 3. Nice. Good. Very good. Okay. Nice. I think the last question is coming up. Good job, guys. Its answer is 3. So nothing is below 3. Name the cause for this condition. Now you can see one pupil is dilated, one is constricted. So name the cause for this condition. A, is it physiological? B, is it oculomotor? C, is it honors? Or D, is it pilocarpinate drops? Or E, is it all of the above? This time I won't cheat here. Yeah. So when you get an option all of the above, mostly everybody goes for all of the above. This time I won't cheat you. This time I won't. Good job. Yeah. Good job. Good job. Nice. Ding. Okay. So this is possible in all of the above. Anisochromia is a condition in which the pupil of one eye is different from the next one, mostly more than 0.4 and above. So, you know what is direct response, you know what is concentric response. You put light to the right eye constricts, direct. You put eye to the right eye, left eye constricts, it is concentric. So when you see this thing in an unconscious or a traumatic patient, this is a danger sign, watch out for it. I think that's it. Merry Christmas to all of you. Okay. Okay, congrats to all of you who have done well in the exams, especially Jamie, Suman, Amla. Good job, guys. I'm happy all scored well. That's
Congratulations, students. I think all of you did a good job, and we are winding up the session. We have with us Dr. George Chandimatindra, our CEO. So I would like to ask him to give you a concluding address on the importance of head injury. So,
I don't know much about head injuries. I just know that yesterday we won the cricket match in Australia only because of the concussion that happened, and then they brought in the right person. It's always good to know, good to learn. I want to thank Dr. Prithvi and Joel and Shami for that excellent session. And I'm glad to see nearly 200 of you still online. I'm sure it was very informative, educative. You must understand that the batch of 2017 has done us proud by giving us the best results in the state. And I hope that all of you, especially 2016, as you come for the clinics, from the 15th of December, we've planned out some very intensive coaching because we not only want you to pass exams, but want you to be excellent doctors. So once again, thank you to all the teachers, the panelists, and for Elizabeth very especially.
Thank you,
and
sir.
Arun Bhaiya sitting here for taking care of the technology to make it so good for us.
Yes.
Thank you so much.
So next class is on December 10th, Thursday. So meet you all on next week, Thursday at 3:30 p.m. for yet another interdepartmental academic session. Till then, wishing you all a wonderful weekend. Bye.